in post-refractive surgery. But if they happen, they can be managed, as you rightly pointed out, very effectively also. No financial disclosure, nothing can happen in a complication type of presentation as such. As you rightly said, refractive surgery is one of the most commonly done procedure in the body, and it is so widely done world over in large number. And any refractive procedure in cornea can weaken the entire ocular structures. And with a minor trauma also, sometimes you can have a serious sight-threatening complications also. They can happen anytime post-surgery. It can happen after many, many years of a surgery also. I think once you have a history of injury in a post-refractive surgery patient, you have to do a very comprehensive examination, look for angle areas, intraocular pressure, lens status, and the posterior segment examination is very, very critical for all these patients for giving them an outcome subsequently. As we know, these patients had undergone refractive surgery to have a best visual quality, and they think after this trauma also they'll regain the same visual quality. Therefore, I think the counseling part is very, very important for these people. So this is a gamut or refractive surgery you can see. Let me talk about incisional surgery, which is not so common now, but you still have radial keratotomies or some sort of incision which we do in a intracorneal ring segments, where with the trauma sometimes the ring can extrude out, or sometimes it can go into the anterior chamber also. So that type of complication you can see, and those managements are quite simple also. But radial keratotomies, the things can be totally different. And you know that sometimes they can have multiple incisions, and they may be more than 80% depth. And I know that larger the number of incisions, more than 12 incisions, and the longer the incision reaching up to the limbus will have higher chances of weak coats. And with the injury, they can open up like a flower petals. So it is a petaloid type of opening which can happen in a post-RK incisions. And unfortunately, many cases have involvement of optical zone also. So this is a young patient who had fight with somebody and had an injury to the eye. He'd undergone radial keratotomy almost 19, 20 years back. And he had a petaloid opening of all the incisions. So we had to put sutures to every incision. And sometimes as you put one suture into one particular incision, other incision opens up. So you may have to do a bursting type of suturing also in these cases. So this is after a few months. You can see entire cornea got decompensated. And this patient ultimately would require a sort of a keratoplasty to give him some vision back. You can see how much edema is there after 1 month of surgery. You can imagine RK per se will cause endothelial compromise situation. And with the injury opening up, incision opening up after injury will again decrease the endothelial function. So these patients may require an optical graft subsequently. This is another example of a patient. In fact, I had reported a similar case here where the incision got infected with staphylococcus after injury, and this never healed unless we put a bursting suture all around to compress all the incisions, and subsequently it will heal. So RK can be very, very devastating if there's an injury to the eye, especially closed globe injuries, and entire eye can open up and things will become very, very difficult as such. Let's talk about flap-based procedure, which is so commonly being done across the world. LASIK as such. It can be a microkeratome-induced flap, or it can be femtosecond-induced flap. But all can get dislodged. They can get avulsed. There can be a flap tear. More commonly, flap stria is very, very common immediately after surgery, or even after a long term after surgery also. And if you have an injury, there are high chances of epithelial ingrowth happening in these patients. Sometimes you can have a scarring also. So this is one patient you can see a flap got displaced and epithelial ingrowth has happened. This is a patient after a total flap melt, there's an infective insult also. And these are epithelial ingrowth which has happened post and the stria, which we saw after almost a month of surgery in this particular patient. You can see the subcutaneous hemorrhage. So this is one incident where the flap got totally dislodged. You can see here the flap is pushed towards the optical center area, and there's epithelial growth also. And as I said, the risk factor may be if you do a microkeratome flap, it has a lesser adhesion than a femtosecond LASIK flap. So you may have more chances of flap getting displaced. Sometimes you can have more folds. You can see normally folds will be radial. You can see folds here is a tangential because there was an injury to this particular patient. So all this is going to cause decreased vision, decreased visual quality, and irregular astigmatism will develop in such cases. And the workup has to be very thoroughly assessed. The cornea, the tear film, ocular surface, the quality of vision has to be assessed, and always look for a other eye which can also have the same problem or maybe better. Accordingly, you can enhance your outcome. Anti-segment OCT is very useful in these cases to assess the entire length of right from epithelium to a deeper stroma part also. The management is difficult sometimes because the flap may be totally wrinkled. So you may have to do as early as possible. You can flatten the entire flap, remove the epithelium first, and subsequently do the assessment. So first, you have to need to see what is the edge of your flap. So once you identify the edge, you can lift the flap edge, and OCT can also give you a lot of guidance. Lift the flap, iron out the flap, remove the epithelial growth, and subsequently flatten this entire area. And mitomycin C should be used in these cases, especially with the epithelial growth being there. So this is a case after we intervene. This is after 1 month. You can see absolutely normal cornea. If you intervene early, you can regain the visual acuity of these patients. So these are other type of flap complications. You can have folds, which can be micro and macro. Micro folds, if they are not affecting visual acuity, may not do any intervention. But normally, post-injury, there are macro folds, and these folds have to be taken into making them smooth. As I said, two important things are there. When you have a macro folds, they are there for longer period. You have to remove the epithelium first totally before you try to lift the flap. Remove the epithelium, then lift the flap. You can iron out the flap, or you can make it hydrated so that ironing is better. And if needed, you may have to put a sutures to put the flap in right condition. Sometimes you may have to put a glue also, especially if your track remaining there in these cases. So this is one example. This patient, I recently saw it in my clinic. The patient had undergone microkeratome assisted LASIK almost 4 years back. Unfortunately, he had an injury almost 1 year back, and because of a COVID situation, he could not come to the hospital. And you can see his vision had gone down to almost 4/60 in this eye, which had an injury. Other eye was almost normal. And with the best corrected vision was 636 only with the irregular astigmatism. So this is a picture here. You can see this is the edge of a new flap now, which has got totally displaced to one side. And this is the area which is exposed because the flap got displaced. And this area has already epithelialized with a little bit of stromal, you can say, opacity here. And this is a large epithelial ingrowth being there in this particular page. This is a retro illumination picture of the same patient. This is the new flap edge. See the folds here, and this is opacity which is developed in this. So I took this patient for a flap amputation because nothing would work on this patient. If you see the pre-op topography, so the steepness, cornea is also thick because there's a epithelial hypertrophy as well as the flaps getting crowded there. This is the OCT picture of same patient, epithelial ingrowth, and this is the folds in the stroma also. So this is on table. You can see what I'll do. I'll try to remove the epithelium first. IOCT picture clearly delineates the epithelial growth and the spaces created underneath the flap and the stroma here. So once I take out the epithelium here, I'll delineate the flap edge with the Sinskey hook. Once I delineate, I'll go through and release the entire flap. So luckily, this was a superior hinge flap. I could remove the entire flap in one go. This area where you have epithelial growth will be little densely adherent. Subsequently, I can do a flap rhexis, as you'll see here. So once I delineate the edges, I'll do a rhexis, remove the epithelial ingrowth with the scraping here. And this will work out for this patient. You can see this is a large flap here. So I'll remove this epithelial growth. A little bit of hypertrophy which was happening in the stroma will also be taken care of. Use mitomycin C 0.02% for at least for 30 seconds to 1 minute. You can see it quite clear now. Though you can see a stromal area still getting little folds. You can see here in the OCT also, put a bandage contact lens. And this is the next day picture. This is the cornea next day, and it looks quite smooth. And the vision has also improved to 6/24, and 6/12 is the corrected vision. And this patient topography wise, this was pre-amputation, and this is a post-amputation. The cornea has become much better, and vision also would improve in next few months. If needed, we can do an enhancement for this patient. Epithelial ingrowth post-trauma is normally associated with the folds and displacement of a flap, but they can be taken care of by various ways we described. This is one patient I saw had a sort of sharp injury to a sharp knife injury to a cornea, which she had undergone LASIK, and see how much scarring is there right in the optical axis with epithelial ingrowth also. So this patient, again, I had to do a flap amputation and do a anterior lamellar keratoplasty to help this patient. So these are a wide variety of injuries which can happen. This is a post-phakic IOL patient, where with the trauma, one of the haptic had come out in the antechamber, and this can happen with the ICL patients also. And treatment will be early reposition with taking care of inflammation, glaucoma in this particular patient. This is after reposition of same patient. And these are cases, I should do a lot of these cases earlier, and this inflammation can occur with the injury, and you have to redo these patients. And resurgery means more endothelial damage, more chances of glaucoma in these patients and cataract. But luckily, we didn't have many patients. I had done around 400, 500. We saw around 8 patients getting dislodged with the trauma. Sometimes you can have a cataract post-injury with phakic IOLs also, and they may have to remove, like Dr. Swapna nicely talked about how to do cataract surgery. This was patient, I did a femtosecond surgery for this patient. Underneath the ICL, you could do a capsulotomy and nucleus softening also. Surgery becomes quite simple. And the ICL can be removed subsequently without opening the incision. It comes out through a 2.2, 2.8 also. And you can do a surgery subsequently very effectively also. So cataract surgery is not difficult post-refractive surgery. Yes, IOL power calculation will be challenged in an RK patient, not in cases with ICL. They are almost similar. To summarize, you can have incisional surgeries, you can have a flap, you can have a lens-based procedure. All of them can have post-injury related problems. If seen early, you can manage them better, and subsequently, you can always counsel them if they need a re-enhancement subsequently. Thank you, Swapna, for getting me into your course. It was wonderful being with you.